Hello friends, in this video we will talk about some general terms regarding respiratory physiology. Now, first we'll talk about ventilation. So ventilation is nothing but the circulation of replacement of air or gas in a space. Nothing but is the circulation of air or gas in a space. Just remember this much. And in this we have two kinds of ventilation, pulmonary and alveolar. In the table we can see the difference is there. So pulmonary ventilation is the volume of gaseous exchange during silent breathing. At the pulmonary vessels it is recorded. So it is recorded during the silent breathing, but the alveolar ventilation is every minute, every moment of the gaseous exchange is alveolar. Pulmonary is during silent breathing. Now the calculation. So pulmonary ventilation is tidal volume into the respiratory rate. See the difference? In alveolar ventilation, dead space is included. Dead space is nothing but it is that area where the respiratory mechanism, that is the exchange of gases, does not happen. The normal value is 150 ml. So pulmonary ventilation is equal to tidal volume into respiratory rate. So we have 500 into 12 or 6000 ml per minute. And alveolar ventilation we have including the dead space. So tidal volume minus of dead space into respiratory rate. Substituting the values, 500 minus 150 into 12, this is 4200 ml per minute. Right. Next we'll go to ventilation perfusion ratio. So ventilation perfusion ratio is nothing but the ratio of alveolar ventilation to that of the pulmonary blood flow, or I call it as the simply blood flow or perfusion. The normal ventilation perfusion ratio is 0.84. Please remember this. It is very important. 0.84. And alveolar ventilation we can calculate like this: the tidal volume minus dead space into respiratory rate. As I already told you, 4200 ml per minute, and pulmonary blood flow is 5000. So divide it, you will get 0.84 roughly. What is the significance? We will see. Now it leads to two important things. One is dead space and shunt. That is, ventilation without perfusion is dead space, the reverse is shunt. And briefly the pathology. If we come to the pathology, we'll have COPD, chronic obstructive pulmonary disorder, where it is affected, ventilation perfusion ratio. Next we talk about compliance. So compliance is nothing but the expansibility of the lungs and thorax. In simple terms, expansibility of lungs and thorax. So why we have to know the compliance? Why we have to know compliance is about the power of the lungs and thorax. Now if we take intra-alveolar and pulmonary pressure, so if taken together, that is the lungs and the thorax together, that will be in the common units which I will be discussing under ml per centimeter water. Volume by pressure, isn't it? So 130 if taken together, 220 if taken separately. Same with intrapleural, just subtract 30 and 20. See, 130, 220 is there. Subtract 130 minus 30, 220 minus 20. You will get 100 and 200. 100 is if taken together, 200 is when taken separately, like this. Now the specific compliance of the lungs is given by the compliance, actual compliance by FRC, functional residual capacity. So we have static and dynamic compliance. The difference between that is this: the static dynamic differences. Dynamic conditions is taken during normal breathing only. Alright. Now it is measured by the PV curve or the pressure volume curve. We have said one more curve like this before. In the renal system, We have the cystometrogram, where there also we have a pressure volume curve to measure the micturition in the bladder, right? This is all about respiration. So we have the pressure and volume. X-axis -1 unit. Pressure can be negative, not volume. Please remember. And this is the volume 100 units. This we can observe. This is expiration and inspiration. This curve is called as hysteresis loop. Please remember this word. Hysteresis loop. Alright. And these are the variations in the complaints. This is for a patient with emphysema. This is a normal patient. And this is for a fibrosis patient. So these are some of the variations. Now, what is this airway resistance we will see? Airway resistance is the ability to block the gaseous exchange into the respiratory tract, or simply it is to regulate the respiratory exchange of gases. That is airway resistance. Same curve only. The same curve we will be using as we said here. Here we can see this is expiration, this is inspiration. Inspiration will be the airway resistance, expiration will be the tissue resistance, and here we will have the compliance. See how much space is there for compliance. Okay, same units. X-axis -1 unit, Y-axis is 100 units. Volume is in ml, pressure in centimeter water. Now coming to diffusion capacity of the lungs. So diffusion capacity is nothing but the volume of gas in the respiratory membrane for a pressure of 1 mm mercury. I repeat, the volume of gas diffusing in the respiratory membrane for a pressure of 1 mm mercury. So for oxygen it is 21, for carbon dioxide is 400. So it is approximately around 20 times. Now through this formula we can understand the relation. The diffusion capacity is directly proportional to pressure gradient, solubility and permeability or surface area. You can write permeability also, no problem. So directly proportional to pressure gradient, surface area and permeability. Inversely proportional to molecular weight and the thickness of the respiratory membrane. Now let us see with the lung volumes and capacities. So as we can see here in this diagram, this is IRV, TV, ERV, RV. Now IRV is inspiratory reserve volume in place of inspiratory expiratory. Here tidal volume, here residual volume. All of this is called total lung capacity. That is nothing but inspiratory reserve volume, expiratory reserve volume, tidal volume and residual volume. And vital capacity, please remember, vital capacity excludes residual volume. Rest all will be included. Now this is inspiratory capacity where we have IRV and TV, inspiratory reserve volume and tidal volume. FRC we have the expiratory reserve volume and the residual volume. Now in detail let us see all the lung capacities and the volumes. Now TV, tidal volume as an amount of air inspired and expired during normal respiration. The volume is 500 ml, all will be in ml, all the volumes and capacities. Then IRV, inspiratory reserve volume, amount of air left in the lungs for normal inspiration. Okay, amount of air left in the lungs for forceful inspiration and normal inspiration. 3300 ml is the volume. Same way expiratory. Just substitute inspired with the expired, inspiration with expiration. That's it. We'll get 1000 ml. And residual volume, the amount of air remaining in the lungs after forceful expiration. Okay, so here exception is that generally it will be normal inspiration. But here ERV and RV is for forceful expiration. Here 1200 ml. Now lung capacities. It is a derived form of the lung volumes. So IC, that is inspiratory capacity, amount of air inspired after normal expiration, that is TV plus IRV. We have 500 plus 3300 or 3800 ml. Then vital capacity, maximum volume of air expelled out forcefully after deep inspiration. So we have TV plus IRV is equal to 500 plus 3300 or 3800 ml. And FRC, it is the amount of air left in the lungs after normal expiration. So that is equal to ERV plus RV. And it is 1000 plus 1200 or 2200 ml. And total lung capacity. Total lung capacity is everything. IRV plus ERV plus TV plus RV. And it is the volume of air in the lungs after deep inspiration. So if we sum up all, 3300 plus 500 plus 1000 plus 1200, we will get 6000 ml. That is total lung capacity. And please remember, spirogram is one important spirogram is what we are using to measure the capacities. We need to remember vital capacity and total lung capacity cannot be measured because it is at the level of deep inspiration. Vital capacity, it is the volume of air expelled out. Here it is no expelling is happening in total lung capacity. But otherwise it will be at the level of the normal expiration only. So that brings us to end of the video. So thank you so much. I will see you in the next video.